Rishi sir, please start. Thank you.
Yeah, thank you, ma'am. Very good evening to all. As we all know that Maharashtra Academy of Pediatrics team has started this new series of academic on vaccinology, Vaccine Samvad, under the mentorship of past president and national IIP and vaccine experts of the globe, Dr. Nitin Shah sir. So this is the seventh episodes. We are coming up with the session, especially on the dengue vaccines. Dengue is now one of the most important tropical diseases. While it does not kill that many people, it has tremendous economic and social impact. So, first of all, I will invite Dr. Sanjay Pakmode sir to say the.
Namaskar. Respected Nitin Shah sir, respected Sham sir, Bhaskar sir, and our own treasurer Dr. Ravindra Sonone. Then the secretary of Dynamic Secretary of MahaIP, Dr. Amol Pawar, convener Dr. Sanjay Deshmukh, editor Dr. Rishi Lodia, and all the CIP members and MahaIP members who have joined today for this particular functions. Now today I received so many calls. Nobody should take it personally. This is just my disclaimer. I got so many calls from the people after seeing the flyer. They were saying now we think the election has been started. Election has been started. I said yes, maybe. Now we are. This is just a 3 months left. So after seeing the so many people who are contesting the elections in the as a guest as well as a panelist, so everybody was asking me if we are also there, why we are not including our names also. I said, sir, now this is the time of the election. Now it's the time to focus on those people. So maybe because of that, because I had seen the flyer just a few minutes back, because this flyer was not shared with me at all. So let it be. Today we are discussing, till date we were discussing the vaccines which are used in the practice, either in the national immunization schedule or the ACVIP schedule. Now today we are discussing a vaccine, which is a vaccine useful in the monsoon period, and again a vaccine which is a forthcoming vaccine, maybe the future vaccine, maybe the early 2026 we may see the dengue vaccine. So today from the experts we are learning on this particular newer vaccine for dengue fever, and because till date the not single dengue vaccine has been launched because of so many things, because of all vaccines are under clinical trials, somebody in the phase 2, somebody in the phase 3, and then the permission from the authorities, and including all the 4 serotypes of the dengue vaccine. So let us learn from the today's experts the infection, which can be a very simple infection, or it can be a very dangerous infection, have a lot of mortality also. So more than lakhs of cases are affected in 2024 with the dengue, but in this year we are finding a very little few cases of dengue as far as this part of the Maharashtra is concerned. So I welcome you all on this platform, and I welcome all the today's attendees to get knowledge about the vaccine, which is still not in the practice, but let us know everything about this particular vaccine, so that whenever this vaccine will be there, we will be will be able to give this vaccine with the confidence. So over to you, Rishi.
Yeah. Thank you, sir, for guiding this. Dr. Sanjay Deshmukh wants to tell. Oh, okay. So I think he's not there. So without wasting much time, for today's session,
Sanjay sir is here. Sanjay sir.
Amol.
हाँ. Unmute करो sir.
Amol आएगा.
Everyone.
हाँ.
This is very nice initiative, and Dr. Nitin Shah sir has taken efforts for conducting this vaccine samvad. Actually, I'm at railway station, so background noise is there. So I welcome all the dignitaries, both the guest of honor, Dr. Ganesh Kulkarni sir, Dr. Jitendra Gawane sir, and Dr. Nitin Shah sir, Sanjay Pakmode sir, then our guests from other states, Dr. Bhaskar Shinay sir, experts, and also Dr. Sham Kukreja sir, and our very own treasurer of Maharashtra,
Ravindra.
Dr. Ravindra Sonone sir. So wish you all happy learning. Thank you. Over to you, Rushi sir.
Yes, sir. Thank you, Amol. I think Dr. Sanjay Deshmukh is there.
He was there. I don't know whether he's still connected.
अनम्यूट नहीं हो रहा है उनका.
Okay, okay. ठीक है,
Sir, try
without
now.
way.
Sir, try now. Sir, try now.
Hello.
Yes. Very good evening. Warm regards from my happy platform, and my regards to today's vaccine expert, our respected Dr. Nitin Shah sir, Bhaskar Shinoy sir, Dr. Kukreja sir, our own Ravindra Abaji. Today we are going to discuss much awaited vaccine, which we hope in next quarter we'll able to have in Indian market. 2-3 companies are in the market, they may launch it, and I hope today with the expert like Nitin Shah sir and all the vaccine expert, we may get some clues when it will be available in India. And I welcome Dr. Ganesh Kulkarni and Dr. Jitu as today's guest of honor, and continue monsoon academic session under guidance of Dr. Nitin Shah sir. So welcome.
Yeah. Thank you, Sanjay. So, without wasting time, I will start. For today's session, we have two guests of honor, Dr. Ganesh Kulkarni sir and Dr. Jitendra Gawane. Slide please. Dr. Ganesh Kulkarni is a Director and Chief Pediatric Consultant, Sanjeevani Children Hospital from Chhatrapati Sambhaji Nagar. He is National Elected Central IIP Executive Body Member and was past Secretary of IIP Branch Aurangabad. He was also past National Scientific Convener. His area of expertise is in infectious disease, vaccinology and nutrition. He has 3 papers published in listed journals, authors on sub-chapters in IIP books, and also had clinical trial experience in excellent vaccine. So, welcome Dr. Ganesh Kulkarni sir.
Rishi, first
Yeah.
introduce Sham sir and Bhaskar sir.
Okay.
चलो फिनिश कर दो जीतू का कर दो चलो खत्म करो.
Yes. So, because I was told first
It's
guest
okay.
of honor.
It's go ahead. No problem. No.
The second guest of honor is our Dr. Jitendra Gawane. He is a colleague of mine. He is Professor of Pediatric and PSU in charge, MGM Medical College, Navi Mumbai, Executive Board Member, and is also consultant pediatrician at Rainbow Child Care and Vashi, Navi Mumbai. He was an Executive Board Member of Central IIP. He was also President of IIP Navi Mumbai in 2021-22 and member of DIP Academic Committee in 22-23. His area of interest is also in pediatric intensive care and vaccinology. So I welcome Dr. Jitendra Gawane.
Okay.
So for the today's session, Dr. Nitin Shah sir, I think he doesn't need any introduction.
Pass forward.
Yeah. He is a vaccine expert, head department of PD Hinduja Hospital, and also chairperson of IIP PHO chapter and fellow IIP and ISSTM. He has edited several books like Textbook of Pediatric Hematology, Oncology, and delivered more than 2,000 guest lectures and orations. So I welcome Dr. Nitin Shah sir for his as a moderator. So for today's session, we have 3 experts as a panelist. First one, Dr. Bhaskar Shenoy sir, who is the head department of Chief Pediatric Infectious Disease Division from Manipal Hospital, Bangalore, and also Honorable National IMA Professor. He was a chairperson of PIDA 2025 and Honorary Secretary of PIDA Pediatric Infectious Disease in 22-23. He was also Joint Secretary of Indian Society of Kawasaki Disease. His special achievement was in Pediatric Infectious Disease Journal, and he was Editor-in-Chief of Karnataka Pediatric Journal, and is editor on books on infection control and grand rounds of PID. He has given 6 orations till now. So I welcome Dr. Bhaskar Shinoy sir as a panelist. Second, Dr. Shyam Kukreja sir. Dr. Shyam Kukreja is a senior most director and head department of pediatric from Max Super Specialty Hospital, Delhi. His interest in pediatric infectious disease specialist. He was past chairperson of PIDA chapter IAP 2018 and he is convener for Immunization Committee Indian Academy of Pediatrics 2005-6. He has contributed several articles in peer revived journals and pediatric book. So welcome Dr. Shyam Kukreja sir. The third one, our own Dr. Ravindra Sonavne. He is the professor and head of the Department of Pediatric from Dr. Vasantrao Pawar Medical College Hospital and Research Center, Nashik. His area of interest in vaccinology and pulmonology and infectious disease. He was also past IAP president in Nashik from 2021. He was also chairman for Nashikon plus Maharashtra midterm CME. And I welcome Dr. Ravindra Sonavne sir for this. So over to Dr. Nitin Shah sir.
Thank you, Dr. Rishi. Thank you, Dr. Pakmude, Amol, all the members of the IIP Maharashtra for inviting me as to conduct this Vaccine Samvad. And I bring you back to the one more episode. And this time we are going to discuss dengue. Dengue, a really dreaded disease. Morbidity as well as mortality, and you never know mortality can happen in whom. And we have been earning to get a dengue vaccine which can prevent mortality and hospitalization. Somehow it is still not eluding us and we don't have it in our country. But we have started with the first vaccine, Dengvaxia from Sanofi, looked very promising, prevented more than 90% of hospitalization, but had fall into disrepute because of increased mortality in children who are vaccinated who are seronegative, and that led to a break of introduction of this vaccine in many other countries. Then came the very exciting Qdenga vaccine from Takeda, and that's the one which we are all looking forward to coming in India. That vaccine has shown remarkable improvement over the previous vaccine in terms of safety and efficacy, and we'll discuss all that. And by the time we digest the data which is generated for the Takeda vaccine, one more vaccine came with the help of NIH USA and Brazil, taking the lead, what is known as a Butantan vaccine, a single dose vaccine. So Dengvaxia 3-dose vaccine, Qdenga 2-dose vaccine, Butantan vaccine single-dose vaccine, and very, very interesting to know that Butantan vaccine, after having a good field efficacy trial in the phase 3, has now been given to 3 or 4 different Indian companies to take it forward, including Panacea, Serum Institute of India, and so on and so forth. So we will be discussing that. And this vaccine, the vaccine from Takeda is likely to come in the next 6 months or so. And the Butantan vaccine, of course, will take minimum 2 to 3 years, if not more, because the Serum Institute has just started phase 3 trial. The Butantan vaccine by Panacea has just reached 50% of recruitment for the phase 3 trial, and so on and so forth. So with that preamble, I start my discussion today, and we have an extremely allied panel. We have Dr. Shyam Kukreja, a great friend of mine, both an ID expert as well as a vaccine expert. Same is what Dr. Bhaskar Shinoy, who is the current chairperson of the PIDA, and he is also a vaccine expert and infectious disease expert. And we have shared many time platform both for the discussion of a particular immunization practice or in general in the infectious disease conferences. And of course, last but not the least, now a very close friend of mine, Dr. Ravindra Sonavne from Nashik. So I start with you, Dr. Sonavne, and what is the disease burden of dengue in India and world over that we should really worry to have this vaccine coming and we are all waiting for the vaccine?
Yes, sir. Sir, we will discuss first global burden.
Yes.
So in 2024, there were around 13.86 millions dengue cases
Correct.
in world with 9,990 deaths.
Correct.
And in 2025, almost 3.4 millions dengue cases are reported, and there are more than 1,400 deaths over the world. Now,
Correct.
almost more than 100 countries are
Endemic.
And now due to climate change, now it is extending into temperate zone also. Almost 3.9 billions globally are at a risk. And
That's
now
almost like 50%
in
of the world
India,
population.
yes,
That's like 50%
yes,
world
and
population is
historical
actually
trend.
living in areas which are at risk for dengue
Yes.
disease. Go ahead, sir.
Yes, sir. And the historical trend is that in 1990, there were 26 millions dengue cases. Now in 2021, there was almost 58 million. So it is almost double. So this is
Correct.
a global trend. Now in India, in 2023, there were 2.89 lakh dengue cases with 485 deaths. In 2024, more than 2.30 lakh cases with 297 deaths. And in 2025, there are around 13,052 cases with 19 deaths. In that, Kerala is highest, which is having 16 deaths and 3,871. Then followed by Tamil
Okay.
Nadu, 2 deaths, and
Okay.
other regions.
Okay,
So
fine.
high
So
burden.
yeah. So I
Yes.
think in the world, we have moved in the last 2 decades by having more than tenfold increase in the number of cases. And mind you, for one case that is actually reported, there are at least 300 more cases in the community which go unreported because they are mild or because they are not tested. And in fact, Dr. Ravindra Sanavani was talking about the numbers in India, which look so small, like 400 and 500 deaths. But mind you, there was a paper by Dr. Hariharan's group. As on 2018, they expected that more than 5 crore cases, that is almost 3.5 to 4% of the Indian population suffers from dengue every year, and there are more than 22,000 deaths, which amounts to almost 5 to 6 billion US dollars worth expenditure. So it's something which we cannot ignore and which we need to focus on, and it can kill both children and adults. And we have seen this mishaps happening in people who are around us. So, Dr. Bhaskar, why bother about dengue fever? I mean, what's so bad about dengue fever? I mean, it's like any other viral fever, right?
Yeah, so the burden is huge as it has been already described. But the unpredictable nature of the outbreaks, it occurs here and there. And second thing is the complications that occur because of the dengue. One is the plasma leakage, then going into shock, irreversible shock, all those things which we have been seeing lot of cases. And
Correct.
also the organ complications, maybe liver, maybe kidney, maybe brain. So there are a lot of things.
Correct.
Third thing is it will be more severe in those who are immunocompromised or.
We'll come to that a little later. Can you define as to in the resource crunch areas, is it difficult to treat dengue? And have we come down on our treatment part? Have we become more smarter that we are actually having lesser mortality? We used to give too much fluid and now.
Absolutely. See, when dengue was first described, maybe it started coming around early 90s or something.
Correct.
The death rate was very high.
Correct.
And we never knew what to do, to be
Correct.
honest with you. And we always tried to give plasma, give platelet, and push blood,
Correct.
all those things. Over a period of time, we know the pathophysiology, we know what is happening, we know what to do. Now, what we know is now that we only fluid, even in the early phases, it doesn't need admission. You can manage at home in the first limit. The fluid.
So I'm sure a lot of us gave 10 cc per kg per hour type of fluid, push them into a lot of fluid overload, and then we struggle to dehydrate the child, and meantime we may go into a severe lung problem and things like that. Now we know maintenance fluid is enough, and you can go by hematocrit. And I think a large chunk of these treatment protocols have come from Sri Lanka, where they have achieved almost 0% mortality. I mean, if you actually look at the data from Sri Lanka, and I have personally seen Dr. Lakku. I mean, it's unbelievable the type of protocol they use with minimal fluid and maximum outlet. Okay, Sham, what are the dreaded complications? Like people worry, you can develop little fever, you are sick, you vomit, you admit IV, that's it. But dreaded complication, like irreversible.
I think Bhaskar pointed out the dreaded complication that is if the patient comes in dengue shock, dengue hemorrhagic fever.
Okay.
And if the patient has come little late, I think it's very tough to save the patient because the patient goes into organ failure and DIC. These are dreaded complications of this thing.
What about
as you were saying regarding Sri Lanka, I think our experience is hardly any dengue patient dies. I think we have learned. For example, you were telling fluid and all that. I think when dengue came, we didn't know what to do. And then in next year, people were telling each other these babies need a mind-boggling amount of fluid. Okay, and then what was happening? By this, we were saving children.
Correct.
But morbidity was very big.
Correct.
Patients were
Correct.
staying for about 2 weeks, 3 weeks. And
Correct.
then we learned the management is nuanced.
Correct.
You have to give fluid so much that you just have a urine output of 0.5 to 1 ml, not more than that.
Correct.
As
Correct.
soon as I have 1
Bringing
ml
up,
per kg more than that,
you actually give
all
more
residents
fluids.
know that is
Yes.
you have to stop IV fluid now.
Correct. So,
Okay.
so Sham, I want you to give a brief comment about a severe dengue hepatitis, a high mortality.
Yes, absolutely.
And,
the problem is it's very different from other hepatitis.
Absolutely.
You do not know, it's very so unpredictable.
Correct.
The patients go into liver failure very rapidly.
Absolutely. Right. I've seen people going into delirium, hepatic
Yes,
coma, and very difficult. And second is the acute necrotizing encephalitis, the most dreaded.
And that's the most dreaded. I think
Yes.
luckily we see rarely.
Yeah.
But once it comes, it's really a very dreadful condition.
So dengue and influenza, these are the two worries during monsoon that can come in. And once the ANE is set in, near 100% mortality. Would you agree with that?
Absolutely.
All right.
Very difficult to say.
Okay. Let's go back to Dr. Sonamne. So who are the patients who are at risk for severe dengue, Dr. Sonamne, in pediatric as well as in adults? Please unmute yourself. Unmute kara, sir.
Yes, sir. Yes. So first, that is age related.
Correct.
So mainly the pattern, this below 6 years. So above 6 years, there are more chances of severe dengue. That is the age specific pattern. Then in infant, especially after maternal antibodies are when around 6 to 12 months, they are also prone for that. Then third,
they may directly get secondary dengue with the first exposure because they already have the maternal antibody.
Hello. Yes.
Did you hear what I said, Dr. Sonamne? Are you not connected well?
No, sir.
No, I said that the infants who have the mother's antibody, when they have the first natural exposure, they behave like secondary dengue straight.
Yes, maybe. Yes, sir. Because
so that's why they are more severe.
So that is also I am coming heterotypic infection. So that secondary infection that can cause antibody dependent enhancement.
Correct. So that's the mechanism of any dengue. But the group which are at special risk for serious disease like immunocompromised,
elderly above 60, pregnant, then obese. Females are also at a risk. Immunocompromised. Then malnutrition, then with chronic heart disease, diabetes, hypertension, then peptic ulcer disease. These are they are prone for
almost the same spectrum, which are also prone to severe influenza, right?
And also, sir, lab predictors means hematocrit more than 40%. Or
that is true. That is in a given case. That's okay. Fine. All right. So, Dr. Bhaskar, Dr. Sonamne mentioned about the antibody-dependent disease or enhancement, and I think that is a worry also with the dengue vaccine. And in fact, as I said, the first vaccine which came from Sanofi went in disrepute because of the antibody-induced enhancement or antibody-dependent enhancement. Can you explain what is the ADE which happens in a natural infection as well as which can be preserved by a vaccine?
Yeah. See, we know that there are 4 serotypes of dengue. And these serotypes, they resemble not fully to each other. About 60 to 70% of their amino acids are more similar. So each one behaves like a different one. Now, as I told, there are 4 serotypes. If a person gets infection with the dengue type 1, he will get a lifelong immunity, a robust immunity, and a long-lasting immunity to that particular type. Also, he will get immunity to other 3 types. But these are called as cross-reactive or
So you mean to say that the first infection will lead to homotypic permanent lifelong protection, but some amount of heterotypic protection which may actually be more harmful.
More harmful.
Correct. So go ahead.
Especially when so they can wane off or become less over a period of time, maybe 2 years or 3 years generally. And when he encounters with the another non-1 type, which
second exposure to a different serotype. Yes.
Due to not the first type, the other type.
Correct.
These antibodies, which are called as non-neutralizing antibodies. If there are neutralizing antibodies, they are very strong and they can get the things done. But if it is a neutralizing antibodies, these antibodies cannot neutralize the virus, but they can get attached to the Fc gamma receptors, and they can enter the monocytes. And then, in fact, the viral replication worsens or increases in such situation. And that is responsible for that secretes more NS1 antigens. And there's, NS1 antigens are more implicated in the severe complications of dengue. So that's how the ADE occurs.
Perfect. And the same thing can happen with a vaccine which is not very potent and can induce ADE if the antibodies are not that strong. So I think this was very much shown in two studies, in fact. One was in Thailand, where they looked at the IgG level and the risk of infection, risk of severe disease, risk of hospitalization, and risk of dengue hemorrhagic fever. And they found that more the antibody, lesser were the chances of any of this complication. And the same thing was replicated in another study in Nicaragua, where also the same thing, that over 5 to 10 years of follow-up, those who had lesser antibody were at more risk to develop clinical disease, severe disease, and hospitalized or getting a dengue hemorrhagic fever. So vaccine has to induce a good antibody for it not to lead to ADE. And there are a lot of studies which had looked at both the IgG and something known as afucosylated IgG1 levels. And these are the two which are very important, implicated in cases of ADE. And we'll come to that ADE. And that also brings also to one more discussion, which we will do later, that Serum Institute of India is making a monoclonal antibody as a therapeutic antibody instead of vaccine. Of course, they are also trying the Butantan vaccine, as I said. And again, they found that you have to take the antibody much earlier in infection, before replication has started, so that the antibody will be able to curtail the virus replication, and then you will not get the disease. But if you come late and take it, is of no use. So I think we have now understood the immunological basis of the ADE, and new vaccine manufacturers are now, that's why, smarter into avoiding this type of problem. Okay, Dr. Shyam, before we jump to the vaccine, which is the main focus today, some confusion about the dengue diagnosis. People do NS1 on day 5, people do NS1 on day 1, they do IgG, IgM the way they want, then they do rapid test or they do ELISA. Can you just clarify once and for all, how should I have a child of PO, when should I do what?
So let's put it what we do in our practice and then compare with other tests. What we do in our practice is we do NS1 by ELISA, and that's a very reliable test. It has a good sensitivity to the tune of more than 75%. And the specificity is almost 95-99%.
But in which day, what window?
I think go it in first 4-5 days. That's quite okay.
All right.
And the problem is, if it is a secondary dengue, sometimes NS1 may not be picked up because antibodies don't allow it to develop.
Correct.
So let's compare it with the other test. Now, PCR. PCR is a costly test. Little more sensitivity, little more specificity, particularly in secondary dengue. But I feel it's a costly test. In our practice, we normally use ELISA only. Now, coming to the third test, which is a rapid test.
Correct.
The rapid test, the problem is the sensitivity and specificity is quite low as compared to our ELISA.
Correct.
Some studies are there where they say if you combine this test with IgM, possibly you may improve the diagnostic yield. I think, but I think the problem is if you have a IgM in first 4 days, it is only positive in 17 to 20% of the cases.
Correct.
And if you do it in 1 to 7 days, then the sensitivity increases to something like 70%.
Perfect.
So people may use this test. If they have gone beyond 5-6 days, you may use that.
Correct.
But I think IgG is not very useful in acute diagnosis of unless you have a titers and all those things.
So I suggest like the standard teaching was your IgM very strongly positive, IgG absent or if at all weak, it is more like primary dengue.
Yes,
If your
absolutely.
IgM is very low but IgG is very strong, it's more like secondary.
Yes,
Does that still hold true?
absolutely hold true.
Generally holds true.
Yes,
But you
absolutely.
can have a severe dengue even in only IgM positive and vice versa.
We have seen severe dengue in primary also.
Correct.
But
Perfect.
it's mostly seen in mostly a phenomena in secondary dengue.
Okay. All right. So I think we have discussed enough about the dengue, the disease burden, the disease pattern, the diagnosis. Now let's.
Sorry, Nitin. The problem may be many times you will not be able to pick up antibodies because the ideal method is PRNT and all that. But I think what we do in our practice, we may miss sometimes, and sometimes there can be cross reactivity with other viruses.
But what I've spoken to the microbiologists, they say generally the screening test, which is your rapid dengue test, are more sensitive. They are supposed to be like that because you don't want to miss one case. But if your RDT is positive, it not necessarily mean it is actually positive, especially if it is not very strongly positive. And that's where ELISA is more useful. Though ELISA takes time, but I think the standard of care is to prove it by ELISA. And now we have PCR available as a monsoon fever PCR, where you have malaria, we have dengue, we have influenza, we have so many other things included. Maybe patient can afford, you can do one thing, but I think ultimately you do a test to manage a patient, and the management is all clinical and based on a simple CBC and hematocrit rather than trying to do fancy tests. Correct? So you can actually save a lot of money for the patient by not doing all these tests.
Most important.
Most important. All right, Dr. Sonamne, now prevention. What are the ways you can prevent dengue?
Yes, sir. Mainly the prevention is by the primary mainly vector control.
Correct.
So in that vector control, we have to remove all these breeding site.
Correct.
The rikame, bhande, tires, then flower pots, plastics. Then second is larvicide. Some gappiche maase kiva bacillus. One is Thuringitis israelensis, that is BTI, for the persistent bodies. They larvae as a larvicide.
So that's true for even malaria.
Yes, sir. In malaria,
same
also.
thing.
And
Correct.
then for adult mosquito control, we can do this spray,
insecticides.
spray marna, but that can be very temporary. Then biological control in Indonesia, Wolbachia infected Aedes aegypti were used. That reduces almost 77% these dengue viruses. Then second is personal protection like odomas, DEET, Picardine.
Full clothes. I think we have lost his
sleeves, full pants, then permethrin coated nets, machardani, then window screens. This is a personal protection.
Perfect.
Then education campaigning, sustained education campaign for a behavioral change, school-based programs, multi-sectoral approach with municipal corporation and environmental agencies, and vaccination is a complementary. It is not replacement. As per WHO, vector control is important. And now that TAC 003 is Qdenga, which will be available in India mostly in 2026. That is also one, but that is complementary. So main is vector control.
Correct. Are you able to hear me?
Yes, sir.
Yes.
Yeah, because I have somehow my screen has become blank, so I'm not sure. Anyway, it doesn't matter. I will continue because you are able to hear me. So, Dr. Bhaskar, now that brings me to the vaccine. So, what are the dengue vaccines available in the world in general, and which are the ones which are in pipeline?
All those things you have already told. But say, as we know, there is first dengue vaccine was the Sanofi, that is Dengvaxia, that is gone into disrepute, and now it is not available. Okay. So that is Dengvaxia, wherein it was it didn't contain any NS1. That was the.
We'll come to that. You can just enumerate the vaccines.
Okay. So one is Dengvaxia, which is not available. Then we have the Takeda vaccine, Qdenga, which is, as you told, it is about to come. And then the Butantan vaccine, which is on the trial side. These are the three major vaccines that are, but there are many other, like they are trying with the subunit vaccine, they are trying with the VLPs and other things. But that is not in the advanced stage of
Correct. And let's not forget the prophylactic monoclonal antibody, not prophylactic, therapeutic monoclonal antibody,
Correct.
which you can use, which Serum Institute is pursuing. So we will also have something of that sort. All right, let's bring to the last question before we discuss individual vaccine. Dr. Sham, the WHO position paper talks about which countries should introduce dengue vaccine based on the serostatus and the type of dengue virus which are prevalent in a particular country. So what is the serostatus in India and what is its bearing as far as the WHO position paper is concerned? Sham, are you able to hear me?
Yes, yes, yes.
Yeah.
You were asking about serostatus.
Yeah, in India. And what is the bearing on the WHO position paper?
Why we want to know the serostatus is because the seroprevalence by age, it tells you what is the intensity of this infection in our country.
Mm-hmm.
For example, in local area, it is, and we know it's all India is endemic, but there are areas where there's a high transmission intensity. These are the areas we have to be focused on, particularly for vaccine.
Correct.
Now, if you take a setting of high transmission intensity, the very important is what's the mean peak age of hospitalization and what is the mean peak age-specific seroprevalence.
Correct.
For example, if you take 9 years, if it is more than 60% seroprevalent, it indicates this is a high endemic area.
Correct.
And if the hospital admissions are occurring at 16 or less than 16, again, this is very high endemic area.
Correct.
On that basis, WHO in 2016 had decided for Dengvaxia will have a 70% cutoff. And then later on, because there was a lot of ADE and all that, and they made the cutoff at 80%. And still, I think there was no respite. There were ADE cases occurring. And as a result, I think they said it's better to do serology before you give the vaccine. And as a result, this vaccine got into disrepute and got withdrawn.
We'll discuss that later. What is the current seropositivity in India at different age group?
I was searching this recently, and there was one publication in Lancet in 2019.
Correct.
And where they said SP9 may range from 47 to 55%.
Perfect.
This is a study by Manoj Moderator.
Yes.
And the second one I was seeing that was a systemic review and meta-analysis by Parsuram Group. And they said it is something like 56.9% pooled prevalence.
Perfect.
And, then they said if you take cases, 3 studies were there where they were community studies. Where they said at 9 years, the seroprevalence in different part of India were 47.6 to 73%, 73.4%.
Perfect.
And this is by, I think, Garg and Padubiri.
Correct. And I think the seroprevalence is more in urban than in rural, almost like 71 to 42%. In men and women is the same. So mosquitoes bite both the sexes equally hardly. And in the southern, it's more at 77% than in the western and northern beds, which is around 60%. But in children who are small, 5 to 8 years, and I think we're going to discuss that, what is the age indication for which you should use the vaccine when it comes. At 5 to 8 years, it's around 30%. So it's not 60% as we would want it to be. And by 9 to 17 years, it comes to around 40, 45%. And in adults, come to around 56 or 60%. So I think this is a bearing on what we will discuss. And what about the types of dengue viruses prevalent in India as on today? Of the 4, which are more prevalent?
I think dengue 1 and 2, particularly in northern India and eastern India.
Correct.
And if you take southern India and western India, it has been 3, 2, and 1.
Correct.
And if you take eastern northeast, it has been 3.
Correct.
So this is what the data shows.
And some DEN 4 in south, though is not seen that commonly in the other parts.
I think Bhaskar can tell us.
Some cases of DEN 4 has been reported in the south, but it is not a huge number.
Correct, very small.
Very
so predominantly DEN 1 and 2, though DEN 3 is coming up since 2005. And I think this is a bearing because different vaccines have different efficacy against one of these 4 DEN type, and we'll discuss that in the next half an hour. So let's now focus on each vaccine. So first vaccine that we discussed, though it went out of disrepute, but that makes us understand as to how you can improve upon is the vaccine from Sanofi, which was Dengvaxia. So Dr. Sham, what was the composition of this vaccine?
See,
And
the
what was the schedule?
was very interesting. They took a yellow fever strain, and it is yellow fever 17D.
As the backbone.
What they did, they made this as a backbone.
Correct.
What they did was they kept the genetic material of yellow fever vaccine, but they changed the pre-membrane and E genes of yellow fever vaccine by those of four dengue serotypes.
Correct. So they created a
Sort of
chimera.
a chimeric. It becomes sort of
Correct.
a chimeric.
Correct.
So what is happening is, because you need non-structural proteins to elicit a T cell immunity.
Correct.
So it was producing T cell immunity against yellow fever. It was not producing T cell immunity against dengue.
Correct.
As a result, this became somewhat a weak vaccine.
Correct.
And then
what was the schedule?
Schedule was, I think, 1 dose every 6 months and 3 doses.
So that is also laborious. You give it now, then after
Absolutely.
6 months and after 12 months, people may forget to come back. So it was both the schedule and the strength of the vaccine, which actually was a problem.
Absolutely.
All right, Dr. Sonavane, this vaccine underwent 2 trials, one in Asia and one in Latin America. Can you throw some light on what was the short-term efficacy in Asia, in the Asian trial?
Sir, in Asian trial, almost 10,275 were the studied. Age group was 2 to 14 years.
Correct.
And the end point was the virologically confirmed dengue.
So what does that mean? What does that
25
mean?
months.
What does that mean? VCD or virology confirmed? It means it's diagnosis done on PCR, not on ELISA.
Dengue, sir, PCR test positive.
PCR based. Okay.
Or NS1
fine.
antigen is positive.
Okay,
and,
fine.
At the 25th 5 months, we have to after first dose. First dose दिल्यानंतर 25 महिन्यांनी आपल्याला
Sir, there are a lot of people from outside Maharashtra,
Yeah,
so we can speak in English.
Yes. So overall efficacy was 56.2 and serotype specific. Serotype for 1 was 50. For serotype 2 was 34. For serotype 3, it is around 78. And for serotype 4, it was 75. So
Correct.
against serotype 2, it was very poor. And there was also a stratified analysis was done. In 2 to 5 years, there was 33% efficacy. Then in 6 to 11 years, 55% efficacy. In 12 to 14 years, it is around 7% efficacy. And hospitalization, it was found that there was more increased hospitalization in seronegative younger age group. And there was relative risk of 7.45 for hospitalized dengue in seronegative age group 2 to 5 years.
No, but at 25, that was not
So-
at 25 months follow-up. That was beyond the 3 years. So I'm discussing the first pivotal trial, 25 months, where the hospitalization was reduced by 67% and severe dengue was reduced by 80%. But the real problem was those which were seropositive and those were seronegative at baseline. The efficacy was 75% versus just 35%. So children below 9 years and those who were seronegative had poor efficacy of this vaccine. All right, Dr. Bhaskar, what about the Latin American trial, which then improvised upon based on what happened in the Asian trial? Can you throw some light on the Latin American trial?
Yeah, though overall there was a some good news.
No,
but,
so further, what age group was there in Latin America?
Yeah, in Latin America, what they found is that there was increased hospitalization in children below 3 years.
No,
And
Latin America age group I'm asking. What age group were tried in Latin America?
I think it is 3 to 9 or something. 3 to 45.
The 9 to 16 years
9 to
actually. They did not take younger children
Younger
because the
children.
Asian trial proved not good efficacy in the younger children. So
Yeah.
they took 9 to 16-year-old children and they actually found very good efficacy because the efficacy is always higher, better in higher age group above 9 years than below 9 years.
Yeah.
So
See,
it was, yeah, go ahead.
Yeah. What they found is that the pre-vaccination serology in those young groups, that is 4 to 8, was only 13%. And that led to the Sanofi going back and doing some method of NS1 detection, wherein they try to differentiate between the vaccine NS1 and the infection-induced NS1. And they found that increased risk in seronegative people. And that is the reason why WHO told it cannot be given below 9 years. And WHO told that pre-vaccination serology is necessary. And these are the two things that come out of that trial.
Correct. So I think to summarize, the Latin American trial, which was done in 9 to 16 years, actually was very positive. In short-term 25 months follow-up with an efficacy of almost 79% in seropositive. But again, the same thing, in seronegative, it was lower. Though hospitalization was reduced by 80% and severe dengue reduced by 90%, but in seronegative, the efficacy was not even statistically significant. So that is the reason why those who are seronegative, this vaccine actually could not be used, and those who are below 9 years, this vaccine could not be used. Now the question, Sham, did this vaccine work against all four serotype, or there was some issue?
See, there was basically this was a flawed vaccine. What was there in this was basically what happens if you really want to protect against ADE and good protection, protection by each strain. Then in that situation, the antibody response has to be almost equal.
Correct.
It is not almost equal. It should be around more than 40-50% equal.
Correct.
Now, what was happening with this vaccine was, they did a very interesting study. They gave this vaccine, and then because this is a live attenuated vaccine, so all serotypes must replicate inside. But they did a RT-PCR on these subjects. And they found the antibodies to 4 were seen in 44%. Antibodies to 3 were seen in only 13%. Antibodies to 1 were seen in 7%, and hardly antibodies to dengue 2. So it means it's very flawed in that way.
Okay.
So you can see the results also, as you have already described.
Correct.
The antibody against 2 was hardly there. Very
Correct.
less. Very
Correct.
less. In
Except
in Thailand study, I think it was less than 3-4%.
So except in intention to treat analysis where they had some
yes, and the 2 I already told, because what happens is you really want to have a T cell response, then there should be definite.
Can someone mute someone who's talking, please? Admin. Yeah, go ahead, Dr. Sham.
And the second thing is the T cell response is not there.
Okay.
So this is the combination of two. And once the T cell response is not there, then NS1 has a free hand after the infection.
All right. So, Dr. Bhaskar, then something drastic happened in Philippines, and we are all aware, including the principal investigator was put in jail along with the public health expert. What happened exactly in the 3rd year and the 4th year after the vaccine was introduced for children in Philippines?
In in that particular country, especially one group who were seronegative, they had increased risk of hospitalization, increased severe dengue, and some deaths also occurred.
Correct. And what age group? What age group was that?
It was they found that the efficacy was in the 4 to 6 years. It was no efficacy in seronegative group, and intermediate in almost 7 to 11 years, and it was more than 12 years group.
No, that is in the trial. I'm saying what happened after it was started using in Philippines.
Yeah, more number of deaths and more number of severe.
In what age group I'm asking? That's what I'm asking.
That was around, I think around 9 years or something like that.
4 to 6 years, 4 to 7 years. All right. So 4 to 7-year-old children, when they were vaccinated, 3rd year after their vaccine, they started having actually more severe disease than in the placebo arm, as was expected. And that led to UN cry. And I think some 200 or 300 children were perceived to have died because of this type of antibody enhanced disease. and that led to the vaccine being suspended. In fact, then the vaccine was suspended for use below 9 years, and those who are seronegative even when they're above 9 years, and was licensed only for seropositive above 9 years. Now that's the problem, that you cannot keep on doing this test in every person before you vaccinate, because that will be counterproductive, and that's the reason why this vaccine failed in its sense. So Dr. Sham and Dr. Sonamne, last two questions. Dr. Sham, can you summarize the flaws with this vaccine? And Dr. Sonamne, is this vaccine available still in use anywhere in the world?
Yes, sir.
First, Dr. Sham.
See, the flaws I told you, the flaws are basically it was not giving good antibody response.
Okay.
And second, the flaw was it was not giving T cell immunity. And
Correct.
third, the result, there were a lot of cases of ADE, and
Okay.
the vaccine went into disrepute. And the
Correct.
third last problem was to do a sero study
Correct.
before
Correct.
giving the vaccine. It was becoming very cumbersome.
Correct. And the schedule also.
And the schedule also.
Correct. Now, Dr. Sonamne, is this vaccine still being used somewhere?
Sir, now the current global status is that this Sanofi Pasteur, that manufacturing, they will be discontinuing from September 2025, and whatever inventories are remaining, that can be used up to the September 2026. Presently, in 20 countries, it is used, but only in seropositive dengue cases, and mandatory pre-vaccination serological screening
Testing
is must, and
Correct.
age group is 6 to 45 years. And in US territory, especially Puerto Rico, there is this Dengvaxia is used with some limited use and preconditions.
Okay.
And
So that
in India, it is never licensed.
Yes,
And no
then in
plan
India,
for
not a single
therapy.
vaccine is licensed. So
Yes,
we are
yes.
not
No, yes,
discussing
yes.
India and the vaccine at all. We are anticipating some vaccine to come. That's why we are discussing today. Okay, that brings us to the most important vaccine, which is likely to hit the market, and that's the vaccine by Takeda, Qdenga. So again, Dr. Bhaskar, how is the composition of Qdenga, and how it was different from the Dengvaxia of Sanofi?
Yeah, this has a backbone Dengue2, that dengue virus 2, as
human.
Yeah. Compared to what was there, as Dr. Sham told, it was yellow fever. But
Correct.
here, dengue virus itself is the backbone.
That is human dengue virus.
Human dengue virus.
Correct.
Was the
Attenuated human to dengue virus itself used as type 2, and backbone used to create chimera for type 1, type 3, and type 4. Correct?
correct.
That's right.
Yeah. And what is the schedule of this vaccine?
Schedule 2 doses at 3 months interval.
3 months apart. So that makes it even easier than the previous vaccine, which was 3 doses, and that to 6 months apart. Okay,
Yeah.
Dr. Sham. That
Now
brings us
here
to
the advantage is that it contains NS1. So
Correct.
the immunity is much better compared
Correct.
to that previous one.
Correct. Perfect. I think I completely agree. Dr. Sham also discussed that the role of NS1 and the role of NS1 antibody. All right, Dr. Sham, this vaccine has undergone one very, very elaborate phase 3 pivotal trial known as TIDES, that is tetravalent immunization against dengue efficacy study. So what was this TIDES study, and what was the result?
I think there were something like 20,000 participants, 4 to 16. It was asked. It was placebo controlled, and
Correct.
in this, I think there were 2 doses given at an interval of 3 months.
Correct.
8 endemic dengue endemic countries in Latin America and Asia Pacific.
Perfect.
Participants were divided into 2:1 ratio, and they were given vaccine, and the other group, which was I think a control group, was given placebo.
Correct.
Now, the main phase of the study was first year, and then the second part was up to 18 months.
Correct.
Third part is 4.5 years.
Perfect.
Like to around 57 months.
Perfect.
Now, what was the results? The vaccine efficacy at 1 year was 80% against virologically confirmed dengue. Very impressive.
Okay.
And prevention
was it same for seropositive and seronegative?
I'll come to that later.
Okay. Okay.
Let's have at a glance what is going on.
Okay.
And vaccine prevented hospitalization in 90% of the cases at 18 months.
Perfect.
So these were very interesting data.
Correct.
Then they wanted to know if this efficacy is going down or not.
Correct.
Not significantly. Now, vaccine efficacy at 57 months
Mm-hmm.
As far as vaccine, virological confirmed dengue is concerned, it is preventing to the tune of 61%.
Correct.
Hospitalization is prevented to the tune of 84%.
Correct.
Now, coming to the last
So,
part.
so before you go to that, in summary, though the vaccine efficacy against all overall vaccine confirm, I mean virus confirm dengue did come down from say 80
to 61%.
61%, but hospitalization prevention remain at very high level
Quite good,
of
more than
85%. And I think our aim in vaccination is to prevent severe dengue and hospitalization rather than just to prevent dengue. Of course, you can prevent all dengue, it's even better, but we should not be discouraged if there's a drop in efficacy, provided the hospitalization efficacy remains very high. Okay, so that's one observation from what you said. Now, coming to seropositive, seronegative, as well as type of dengue viruses and the efficacy.
So, coming to vaccine, coming to virological confirmed dengue, if the average is 61% at 57 months,
correct,
it is 64% in case of
seropositive,
seropositive, and 53% in case of seronegative.
Correct. But again, hospitalization.
Okay, and now coming to hospitalization. If it is 84% in general, it is preventing in 85.9 or 86% in seropositive and 79% in seronegative.
Correct. So that's again very, very encouraging.
Difference it looks like.
Perfect.
Now coming to 57% seropositivity in dengue 1, dengue 2, dengue 3, dengue 4. More than 50% most of the cases, but dengue 2 is 80%.
Correct.
And in case of you take it seronegative, you are getting efficacy to the tune of 45% in dengue 1, 88% in dengue 2, but you are not having any data, particularly dengue 3, there's hardly any prevention, and there were not sufficient cases in dengue 4.
Dengue 4, correct.
So you can say and summarize that as far as seropositive is concerned, the vaccine is effective in preventing hospitalization in good number of cases.
Correct. Overall and against all
negative is concerned, we are not having any protection against 3, and 3 is a significant disease in India also, and we do not have data for 4. So this is the summary.
So how do you then tackle this Dengue 3 and Dengue 4 when the trial did not have enough cases of 3 and 4? Are we looking at some other effectiveness data in countries where it is now used as a post-marketing surveillance?
Yes, I think post-marketing, and they are, I think, doing a study of 70,000 plus subjects, and possibly the answer will be given by that. The good part is, so far, there's no concern about ADE.
Correct. So Dr. Bhaskar. Yeah, go ahead, Shyam.
Yes, I was saying that there's no concern about ADE so far with this vaccine.
Fine. Correct. So we discussed that there's a long-term data up to 54 months available with this vaccine without any AD. So we'll skip the next two questions, which were actually the same. So let's come back to Shyam. Is there evidence of efficacy in seronegative versus seropositive subject? You already said that it is equal in the short term, and especially against hospitalized patient. And I think that is an important aspect of this vaccine, that even in younger children, the vaccine worked well in both seropositive and seronegative, and worked very well for hospitalization even in seronegative children, at least for the Den 1 and Den 2 virus, may not be for Den 3 and Den 4 virus. All right, Dr. Bhaskar, what about the age group and efficacy?
Actually, Dr. Sham has already told. The thing is that, as he has told, there are no cases of dengue 4 and dengue 3. The age group of younger the age group, that is less than 8 years, there is a reduced efficacy. So with that, the 4 and 3 cases are not there. So there are not much of data about that. So when it comes to practice, even across the country, each geographical area, there are different types of serotypes, as it has been already told. So we have to wait for the post-marketing surveillance and see whether it is effective in seronegative groups.
Correct. So just to recapitulate from what Dr. Shyam said and what Dr. Bhaskar said, at 18 months, when the age-stratified efficacy of this vaccine was looked at against all-cause VCD, that is virological confirmed dengue, for younger children as young as 4 to 5 years, it was very high at 72.8%. In 6 to 11 years, it was 80%, very similar. And in 12 to 16 years was again very similar at 83.3%. So this vaccine works equally well both in young children as well as in older children. And when it comes to 54 months data for hospitalization, even in younger children who are 4 to 6 years, even when the efficacy has dropped in seronegative children to a non-statistically significant, but for hospitalization, it still looks good at around 80 or 85%. So I think that's the question that we will have to keep in mind when it comes to 4 to 6-year-old children. And I am going to discuss that because this vaccine in WHO says only above 6 years, though some countries have licensed it even from 4 years of age onwards. The efficacy at 54 months in 4 to 5-year-old children in seropositive was very high, 54.1%. In seronegative, it was statistically not significant. But for hospitalization, it was 63.8% in seropositive and almost 67.8% in seronegative, though numbers were small to give any statistical significance. So I think when it comes to our country, and where again, as we said, the seroprevalence in younger children is not as high, is around 20 to 30%. We'll have to take a call as to are we going to, in India, suggest this vaccine to be used as young as 4 years, or are we going to restrict it only above 6 years of age? All right, Dr. Sham, what about the booster data? Because this study also had a built-in booster age group up at 4.5 years.
I think there was nothing significant as far as booster is concerned, as far as I know. I read a study a few days ago.
Correct. So I had just a talk with the Takeda group, and I think in the upcoming WISPID conference, this booster data is going to be shown in the form of a poster and maybe some presentation. But what I understand is that first of all, it was restricted to only children for the booster and not for the older age group. And when they gave the booster, though there was no increase ADE, and I think that's very important. So by giving booster, there was no increase ADE as what happened with Dengvaxia in the 4th and the 5th year, but it did not have much increment in the term of either antibody response or in the term of an efficacy. So I think maybe once we know the full data set, we will be able to take more judgmental decision as to whether we should give a booster to younger children to boost their efficacy, because as we said, younger children, the efficacy is not as good. So Dr. Sonamne, now, can you summarize based on this, what are the advantages of this vaccine over the Dengvaxia vaccine from Sanofi, which we said when it will disrepute?
Yes, sir. So there are first implementation advantages. In this, no pre-screening of this dengue positive or seropositive is required.
Perfect.
Then second is simplified 2 doses.
Correct.
First at 0 and second after 3 months.
Correct.
Then broader age specification. In that we can give above the age of 4 years this vaccine. Dengvaxia generally it is given in between 6 to 16 years. Now safety profile, there are no risk of this antibody dependent enhancement risk. Then favorable benefit risk ratio means efficacy is almost equal in seropositive and seronegative.
Very good.
Efficacy advantage, it has a superior then to protection. It is almost 82% versus Dengvaxia in that it was a 34 to 35. And then sustained hospitalization protection as discussed by Sham sir, that was 84.1%, and it is a consistently performing. So
and no ADE.
Also, sir, also it is a WHO pre-qualified, and we can give it to travelers also, and we can integrate into routine immunization schedule also. These are the advantage.
Correct. And there was no AD on long-term follow-up up to 54 months.
Yes,
so that makes it very, very important. I think the younger children who are given booster at 4.5 years are going to be followed up for the next 3 years. So that will make it almost 7 years follow-up for those young children with or without booster. And I think it will be very interesting to see what happens in this long-term study over the next 2 or 3 years. All right. We must also caution here that this vaccine had a voluntary withdrawal in Singapore. Essentially not because of any efficacy or safety issue, but because number one, there is a very low prevalence of seropositivity in Singapore in general, and they have a DEN3, which is a very common virus there. And as this vaccine has not shown efficacy against DEN3 in seronegative, and as most of the population is seronegative, that's why it was voluntarily withdrawn from Singapore. And there has been a voluntary withdrawal from USA. Again, there is nothing to do with efficacy or side effect, but more to do with issues with the data collection, and there was some dispute between the manufacturer and the data that was captured and the data that US FDA wanted it to capture. And I think they are still working on to resolve this issue so that maybe this vaccine will actually become available for use in USA. So I think an extremely important vaccine, very safe, very effective, both in seropositive, both in seronegative, long-term data, with or without booster, at least in above 6 years. So definitely there is no issue of efficacy at all. This is the one vaccine which we are looking forward to in use for our country. But as I said, there is another vaccine which is knocking at the door, and that's the Butantan vaccine. Very exciting vaccine because it's a single dose vaccine, and exciting because Indian manufacturers have been given the technology transfer, and I am sure Serum Institute of India and Panacea are the two, along with some one or two more company which are looking forward to this vaccine. So, Dr. Bhaskar, what is the Butantan vaccine and what is the schedule?
The vaccine has all four serotypes in the sense 1, 3, 4, but for backbone for 4 is 2, the Dengue virus 2. Correct. So that mimics natural infection. It is given as a single dose, and it has been found to affect even the innate humoral and cell-mediated arms of the immunity. And they've even studied the antibody levels and the cell-mediated immunity. And it is
so you mean to say there is only one chimera for type 4, and the remaining 1, 2, 3 are naturally attenuated type 1, type 3, type 3 human dengue virus as the vaccine virus.
Chimera 2 and 4.
Correct. All right. Now, Dr. Sham, again, what is the data on this vaccine available so far?
See, this has been studied in 2 to 6, 7 to 17. It has been studied in 18 to 59. Means all age groups.
Correct.
All age groups. And
so 2 to 59 years.
Yes, absolutely.
Okay.
2 to 59.
Perfect.
And,
all right.
It is supposed to be 80% effective with single dose.
And
but in short term, yes, and seronegative is 73% and 89% in seropositive.
But what about DEN3, DEN4 again?
Again, the problem is they could not study DEN3 and DEN4 because there were no cases.
Okay. So far as the data suggests,
the data is impressive.
That is impressive. And very recently, they published the 37 months long-term data, which again showed there is some dip in efficacy of around 5 to 10%, as has happened with even Qdenga, but the vaccine efficacy is still working. So overall, in short term, it looks a good vaccine, but it's in India. Dr. Sonamne, will it work against all 4 serotypes because the type 3, type 4 data is not there? What do you think will happen with this vaccine for the type 3, type 4? Because we have type 3 and type 4, at least type 4 in South and type 3 is emerging since 2005. Dr. Sonamne?
Yes, sir. Sir, please repeat, sir. Hello.
Yeah, go ahead.
Yes, sir. Please repeat question.
No, this Butantan vaccine has shown in the clinical efficacy trial only again type 1, type 2. There were no type 3, type 4 cases. So what do you think will happen if, because India is going to probably use this vaccine in the national program when Panacea study is positive and Serum Institute study is positive. What will happen to the remaining 2 types?
Regarding this Butantan vaccine, sir, right?
Yes, correct.
But sir, even if there is a gap data about the Dengvaxia and Dengvaxia, this study was done in Brazil. At that time, there was this Dengvaxia and Dengvaxia was not circulating.
Correct. So what will happen when it comes to India? You think India will give the answer because India is going to enroll phase 3 trial, efficacy trial. Probably we'll have DEN3 and DEN4, and we will be able to come to some conclusion whether it will work against DEN. Because the absence of evidence is not the same as evidence of absence.
Right, sir.
So I think it will be good. Yeah, it will be good because I mean, when we have type 3 in India, and if they're going to work against efficacy in India, maybe we will get the answer whether this vaccine is going to work against type 3 at least or no. Because the type 4, unless there are enough cases, will be a problem even when it's studied in India. Okay, Dr. Bhaskar, long-term data with this vaccine, any further studies are contemplated?
Yeah, as of now, I think 3.7 years plus in some centers they have followed up to 5 years, if I'm not wrong.
Okay.
Yeah.
So
So more
median
than
is
that,
3.7, but the actual range is from 2 to 5 years.
2 to 5 years. So
Right.
up to 5 years they have studied now.
All right.
We have to look for the long-term data.
Okay, Dr. Sham, any idea about what's happening with the Panacea dengue all vaccine?
The seed of TV 003 and TV 005 has been given to Panacea, has been given to Serum Institute, given to IIL,
Correct.
and all these three companies have it.
Correct.
And as a result, I think Panacea is far ahead as far as stage 3 trial is going on. And in this, out of I think 10,000 something, they have recruited 8,000 candidates.
So almost
And
50%.
Absolutely, 80%. And they want to complete it in next few months.
Correct.
And then the results are likely to be there after maybe 1.5 to 2 years.
Correct. So ICMR is actively involved in both
Yes,
Panacea's
absolutely.
vaccine as well as Serum Institute vaccine. And
it is very similar to Butantan vaccine.
Correct. So, Dr. Sonane, you have any idea about this, the Serum Institute's Densil? What is the progress?
Yes, sir. That Dengucil progress, that phase 2, they have completed at May 2024. They are also working on this same this TV003 and TV005 that was invented by NIH, National Institute of Health, America. So around 10,000 will be enrolled in phase 3 studies, this serum study. And this dengue all, dengue all, these are working in 18 centers, 18 states, around 20 centers.
Correct.
I think they did first in Australia with a small group of adults.
That was phase 1-2 trial.
Yeah,
that was phase 1-2 trial. Now the phase 3 is going on in India, and I think as Dr. Sham said, more than 50% recruitment is already over for the Panacea's vaccine trial, and Serum Institute has applied to start with phase 3 based on their phase 1-2 data, which they've just submitted to the DCGI, is what I learned from them just day before yesterday. So probably they are a little behind, but it'll be interesting to see what happens to this vaccine trial. All right, Dr. Bhaskar, what are the WHO recommendation for introduction of dengue vaccine in any country? Now that's going to be the bearing for even ACVIP, because generally ACVIP will take the same stand as what WHO has taken.
Yeah, say WHO recommends that this vaccine has to be given in high dengue transmission areas. The high dengue transmission means the seropositivity at 9 years should be at least more than 60 to 70%, and the peak dengue hospitalization should be within 16 years, below 16 years.
Correct.
So these are the two groups which are labeled as high dengue transmission areas. In one given country, the whole country may not behave as a single entity because each areas may be different. So WHO recommends like that it should be given to those in high transmission areas.
And that too in 6 to 16 years old subject, unless they are having comorbidities like sickle cell, diabetes, hypertension, etc. Even up to 60 years, you can extend the age limit. So generally, it is saying that is a more of a pediatric vaccine rather than an adult vaccine. The last thing, Dr. Sham, there have been inclusion of anaphylaxis as a precaution in the Qdenga, that is Takeda's vaccine. Can you throw some light on what is this anaphylaxis business about?
I feel with any new vaccine, this is always a concern. I think all the pediatricians should be ready to manage anaphylaxis in their practice.
Because
I think the post-marketing data will give more information on this.
so actually, post-marketing, when it was used in Brazil, there occurred 16 cases of anaphylaxis. That almost makes it 4.4 per 100,000 doses. That's like very small number, including 3 cases which were anaphylaxis with shock. So that makes it even lesser at 0.8 per 100,000. And that was the initial phase when Brazil introduced this vaccine in the national program. And now more million doses have been used in Brazil, and the number of anaphylaxis have not been the same in the later part. So probably this incidence may even get diluted further. But just because there was some case of anaphylaxis, like would happen with any new vaccine, the product insert does mention anaphylaxis as a precaution to be seen, and it very clearly says that as there is no data, it is contraindicated in pregnant ladies and in immunocompromised hosts, and also for mothers who are breastfeeding, because we don't know what will happen to the babies if they have fast passage of these antibodies from the mother's breast milk to the child. All right, the last question to all three of you. Suppose this Qdenga comes tomorrow in India. So first, Dr. Sonamne, whom you will give? Children, adult, and what age?
Sir, so Qdenga above the age of 4 years. 4 years.
So you will give from 4 years and not from 6 years.
I will give 6.
Because study safety was found up to also 4 years. That's why.
All right, Dr. Shyam.
Talking about the 4 years.
Dr. Shyam.
I think the age of hospitalization is very important. First, endemicity, and what's the transmission intensity, and second is what is the age of hospitalization. In my experience, I like to find out from others also. Most admissions tend to occur in the adolescents in pediatric practice, say maybe 10, 11 years to 18 years. So they are the most cases. Whenever there's obesity, we always worry this patient is going to worsen a lot because obesity is quite common. So in these cases, I think if you have to give the vaccine, I think I'll go with WHO. Giving after 6, 7 years is quite okay.
So between 4 to 6 years, even if it's licensed, you will not want to give because the seropositivity.
Even the data of this vaccine is nothing great between 4 to 6
4
years.
to 6 years. All right, Dr. Bhaskar.
I do agree with Dr. Shyam. I will give after 6 years. But 4 to 6 years, I will wait for some more data to come. And then only I will start vaccinating.
Absolutely.
I will definitely give after 6.
Okay. If I have to give my choice, I will probably give it from 4 years, because between 4 to 6 years, even though seroprevalence is 30%, the efficacy is more than 50% in those who are seropositive. There is no ADE, though it's a theoretical risk. And hospitalization is prevented to the tune of 65%, though statistically not significant because numbers are small. So that doubt of benefit, I would probably give if there is no ADE to even children between 4 to 6 years, but that's completely my own personal view. So I think with that, we would end today's discussion. We had a very fruitful discussion on a vaccine which are still not available. I'm sure the delegates must be wondering as to vaccine is still not available and how much data is there for them to digest. But I think it will be good understanding for them to study this vaccines and see their pivotal data in the phase 3 trial and be prepared, because this is not as simple as hepatitis B has come, you give it to every infant who is born. Hepatitis A has come, you give it to every baby at 1 year of age. You don't worry about the safety and efficacy because they are proven. This is one vaccine where there is a lot of nuances at age group, seropositive versus seronegativity, and Den 1, Den 2, Den 3, Den 4, each serotype having its own efficacy issues. So you have to make intelligent guess as to how best you will use this vaccine in your day-to-day practice. I think with that, I will hand over the mic back to the organizers to do the curtain closing. Dr. Rishi and Dr. Pakmode.
Yeah. Thank you, sir. Sir, question from the chat box.
Yeah, please. As I
Sir,
said,
one.
my screen is blank. I am not able to see either of you now the chat box.
Okay.
So you'll have to
Sir,
read it, please.
one question was there was as Dr. Shanai had told about the Butantan vaccine,
Yes.
whether will affect the all the arms of immunity. So will this vaccine affect blood test done for dengue, and can we get false positive reports?
Okay, Dr. Bhaskar, will you answer that question, please?
See, you
Will
mean the
vaccine
NS?
interfere with testing of dengue? That is the question.
Yeah, I don't think any studies are there, but I think there will be a problem of interference with the testing because
Dr. Sham?
NS1 is there.
Yes, I think with antibodies, but not with NS1. Not with NS1.
All right. Second question.
Yeah, second question was there. What are the potential application of this vaccine research for other diseases like Zika virus and yellow fever vaccines?
Right.
Please
Dr.
repeat the
Bhaskar.
question.
What are the potential application of this vaccine research for other flaviviral diseases like Zika and yellow fever?
I think it should be very promising if you are, because they're not found the serotypes of those.
And even sometimes it so happened in Zika endemic areas, they have developed with the first dose of dengue vaccine, they have developed ADE because that Zika cross reactivity that has acted as a primary infection.
Yes.
So that has occurred in some areas, but that is being investigated. Yeah.
So
Okay.
I asked a question, sir. Is there like multiple flaviviral we can incorporate in the same platform like chimeric vaccines and all in future?
Oh, like that.
अभी 4 ही कामयाब होने दो.
Yeah. Time alone will tell, sir.
Let these 4 serotypes be successful first.
Okay.
Yeah. One more this question has come that this monoclonal antibody regarding dengue shield represent a promising first ever specific treatment for dengue infection, not a vaccine. So dengue shield could fundamentally shift dengue management by reducing progression to severe disease.
You're talking about monoclonal antibody?
Yes.
Yes, sir.
Yeah.
So the monoclonal antibody are not a combination of 4 monoclonal antibodies. They are just one single monoclonal antibody against a common domain of an antigen which is common to all 4 serotypes. So that's the first and the foremost thing. So it is irrespective of the serotype. Number 2, the monoclonal antibodies have to stop replication of the virus once the disease hits, which means the disease has to be caught early. When 1 or 2 days of fever, you do dengue PCR is positive, you give them the monoclonal antibody. After the child is hospitalized or the patient is hospitalized and you try to give monoclonal antibody, it will not work because it works by preventing the uptake of the virus and the replication of virus. And they have found it very difficult to do this type of study for the simple reason that people come late in dengue. By the time they come, they are so sick, they actually monoclonal antibody. It's like the same as COVID antibody. You know, you had this Regeneron antibody, which a lot of people in USA took when they developed mild COVID to prevent its going into severity. Similar, something like that is something what this monoclonal antibody is looking at. But it has found in the phase 1 and 2 trial that it actually prevents replication of all the 4 dengue viruses to the tune of 100%. So if this antibody is going to be cost effective, it is one way of preventing severity of dengue in someone who is already infected for whatever reason.
And particularly in high-risk cases.
But of course, like in COVID high risk, those who are diabetes, obesity above 60, maybe same thing will apply here. And also the cost, because cost is really, all monoclonal antibodies are extremely expensive, as you know. All right. Are there, yes, Jitu, one more question? Yes, go ahead, Jitu.
Yes, sir. Like what happened with Sanofi vaccine? Is there any fear with this vaccine also? Because India is a large population in a public domain. If we introduce this vaccine, anti-vaxxers are always there.
So remember when it came to Dengvaxia, you look at the Kaplan-Meier's, those graphs. It tells you after you're done an intervention, the placebo arm will keep on rising in the disease pattern. If your intervention is good, it will start spreading and becoming more and more wider. Now, in Dengvaxia, after 2 years, they started merging. It tells you that the vaccine efficacy went away and actually started leading more disease. Whereas for this Qdenga vaccine, even at 54 months and beyond, for those who have taken booster a little longer follow-up, the graphs are still diverging from one another, which means the efficacy is now because with Dengvaxia, the AD happen in children who are seronegative and below 9 years. At 3 years after the last dose, WHO compulsory made it compulsory for all the new vaccine to have follow-up of at least 3 to 4 years after the last dose, and that's the reason why this 54 months follow-up for the Qdenga comes in, and it is very reassuring that there is no AD. So to my mind, there is not going to be any AD. Whether it will work in seronegative in younger children as good, that's the question we debated, but at least there is no harm done as what happened with Dengvaxia.
And as we said,
Thank you.
sir, different countries, different population is having a different sero type prevalence. Like Singapore
Correct.
is having their own, and we are
Correct.
having our own, and African countries are different.
Correct.
So does that will change the efficacy in overall effectiveness in the field?
In fact, if you look at those who develop dengue in spite of vaccine, and you look at the severity by platelet count, plasma leak syndrome, etc., it was much lesser in vaccine versus the placebo. So, if it doesn't prevent hospitalization and severe dengue, at least it will ameliorate the clinical severity. I think these are all very real. Now, you cannot have 100% efficacious vaccine. That is eluding. Maybe a 4th or 5th vaccine may come, but till then, you don't deny benefit of something which is proven today in pursuit of having something which is perfect tomorrow. So we don't start like that, and I think we should start using this vaccine when it comes in a given situation.
Yes,
this is one vaccine like COVID with the community will want.
Yeah.
Otherwise, we have vaccines which we want, but community looks at with a lot of suspicion. But this is one vaccine where the community will want it because they have seen dengue means सबके पैर कांपने लगते हैं.
Absolutely.
Yes, sir. So back to
Ganesh sir, your comments, please.
Dr.
Ganesh sir.
Would do not freeze live attenuated vaccines. Freezing destroys vaccine potency. Okay, fine. So very interesting. This question was also coming Vaccine Samvad. If you know the Qdenga vaccine, the diluent is 0.22 saline. So if you break it, there is no 0.22 saline available. So you have to be very careful. Like for other like distilled water and all, you can actually substitute with any other distilled water or a normal saline vaccine with other normal saline. This is a very peculiar 0.22% normal saline. So be careful when you have this vaccine. Don't drop the diluent. It's a freeze-dried vaccine.
Same was with HIB also 0.76% something.
Yeah, correct. All right, Rishi, concluding.
Yeah. Thank you, sir. For such a nice discussion from basic dengue virus to the enlightening about the future vaccines also regarding dengue. And I thanks all Dr. Nitin Shah sir being a moderator for this today's session, and Dr. Bhaskar Shenoy sir and Dr. Shyam Kukareja sir for giving their time for this program. I also thanks Dr. Ravindra Sonone sir and our special guest of honor Dr. Ganesh Kulkarni sir and Dr. Jitendra Gawane sir, and especially I also thank our MMC observer Dr. Sagar Bhalerao from Nashik, and last and not our chairperson Dr. Meena Sheikh sir, convener Dr. Sanjay Deshmukh, and our own Dr. President Dr. Pakmode sir, and Secretary Dr. Amol Pawar sir, and Treasurer same Dr. Ravindra Sonor sir. Thank you for this Vaccine Samvad program regarding a very interesting topic for dengue vaccines. Thank you, sir.
So the next session will be on the 5th of September, the first Friday of September, and I will announce which vaccine we will discuss in short time.
Thank you.
Thank you, Rishi, for wonderfully
Thank you, Rishi sir. Thank you,
Thank you,
Pallavi ma'am.
Thank you very much.
Thank you, Shyam,
Thank you.
Bhaskar, Dr.